And we're going to move on to our next speaker, who is Dr. Aimee Pierce, who will talk about sleep disruption in Alzheimer's disease. Dr. Pierce is an assistant clinical professor in the Department of Neurology at UC Irvine, and she's also the medical director of the UCI Mind Memory Assessment Center. Her professional expertise is in the diagnosis, treatment, and research of dementia. She completed her residency program in neurology at UCLA and a geriatric neurology and dementia fellowship at UCSD, and she plays an integral role as an investigator on several clinical trials and is a critical member of our clinical core. So welcome, Aimee.
So I'm very glad to be speaking with all of you today about sleep disruption in Alzheimer's disease and other dementias. A brief outline. First, I'll speak a bit about background information about sleep and biology of sleep. Then I'll speak about the changes that occur in sleep architecture in aging and also Alzheimer's disease. Then I'll speak about the sleep disorders in Alzheimer's disease, treatment of the sleep disorders, and sleep disorders in other dementias as well. And so although we spend almost a third of our life sleeping, the underlying purpose of sleep is still an enigma in science. And there may be actually several purposes. One may be a restorative purpose, and several mechanisms in wound healing, growth, and immunity occur during sleep. And if a person's sleep deprived, they may have deficits in these areas. Sleep also may function as an energy conservation mechanism and even a mechanism for safety. So animals or humans may retreat, fall asleep, be quiet in dark time hours when they may be vulnerable to predators. Sleep may also be quite important for memory processing and consolidation of memories that occur, and a great deal of research is focused on this area. There are changes that occur in sleeping as we age, and there is a common myth that older persons just, quote, need less sleep than younger persons. That is not actually the case, although older persons certainly often get less sleep, although they don't need less sleep. And some of the characteristics that happen as people age with their sleep is their sleep becomes more fragmented, which means there's many more times of wakefulness during the night. They are also susceptible to less deep sleep. This is the stages 3 and 4 sleep of non-REM sleep. And they also acquire less REM sleep, or the dream sleep. And this is a standard graph which shows the sleep cycles. And on the top, we have the standard sleep cycles in young adults, and on the bottom we have we have an example of sleep cycles in older persons. And during sleep, a person transitions from wakefulness through light sleep, stages 1 and 2, and then to stages 3 and 4, which is the deep non-REM restorative sleep. And then at the end of a sleep cycle, they have some REM sleep or dream sleep, shown in the dark bar. Each of these cycles tends to be about 90 minutes in length. There can be a few awakenings during the night, but what's noted is that in young individuals, the majority of the non-REM sleep occurs early in the evening, and the REM sleep tends to become longer and more common in the end of the evening or close to the waking hours of morning. What's most striking in looking at the diagram in older persons is, first of all, there are very, very many more awakenings through the night, which is at the top of the graph. You can see that there's much less deep sleep, stages 3 and 4, and the majority of time during sleep is spent in stages 1 and 2. In addition, there's less total amount of REM sleep, and the REM sleep is much more fragmented. And now just a bit about the biology of sleep and the biology of circadian rhythms. And so much of this is controlled by the suprachiasmatic nucleus in the hypothalamus, which is important for controlling many different circadian rhythms, which are our body rhythms, which are running on a 24-hour cycle related to sunlight. And the suprachiasmatic nucleus in the hypothalamus receives input from the retinal ganglion cells. And these are neurons in the back of our retina, which are sensitive to light, and sends an impulse message back to the hypothalamus and can then entrain our own body rhythms with the light and dark. Then the suprachiasmatic nucleus in the hypothalamus sends signals to other hypothalamic nuclei. Hypothalamus is very important for controlling body temperature regulation, appetite, thirst, and sexual desire. And also the suprachiasmatic nucleus sends input to the pineal gland, which is important for secretion of melatonin and has a soporific or sleeping effect. Okay, so there are some standard changes in the sleep cycle that occur in Alzheimer's disease, and many of these are similar to those changes seen in normal aging, but more severe. And again, in Alzheimer's disease, it's seen in comparison to others of the same age. Sleep efficiency is further decreased, so more time in bed is spent awake than otherwise would be. And again, the proportion of time spent in stages 3, 4 sleep and REM sleep decreases. And also the REM sleep latency increases, which means it's later in the night before the person has their first REM sleep epoch. These are some of the most common sleep disturbances that occur in Alzheimer's disease. First being nighttime agitation or sundowning. Second being insomnia. Insomnia affects up to 48% of patients with Alzheimer's disease. Next being circadian rhythm disturbance, which occurs when a person is not sleeping at night and awake during the day, but has some dysregulation of that. And the final being obstructive sleep apnea. We'll speak about each of these. So nighttime agitation or sundowning is confusion or agitation that occurs in patients with Alzheimer's or other dementias that is worse in the evening. And there may be several contributing factors for sundowning. The first may be darkness itself, and so a patient may have reduction in their visual input, which leads to more confusion, not knowing where they are, not knowing their full circumstances. The second may be fatigue, and just towards the end of the day, as a person becomes more fatigued and they have less cognitive reserve, they cannot function as well cognitively. Another may be nightmares or confusional arousals. Patients with Alzheimer's disease may be prone to nightmares and then have difficulty when they wake up distinguishing between the nightmare and reality. And the final may be medications that can worsen sundowning. And in fact, sometimes the medications given for sundowning can actually worsen it and cause paradoxical agitation. Okay, insomnia and Alzheimer's disease, as I said, this can affect up to 48% of patients with Alzheimer's disease. And it's classified based on the time of the evening when it occurs. If the patient has difficulty falling asleep, it's onset insomnia. If they have problems where they wake up in the middle of the night and then takes them quite a while to fall back asleep, that would be middle of the night insomnia. And then if they wake up too early in the morning, perhaps 3 or 4 in the morning, and then are unable to go back asleep, that's terminal insomnia. And there can be many contributing factors to insomnia and Alzheimer's disease. Part of it may be the underlying disease itself, which we'll see, but there are many other contributing factors. For example, pain, cardiorespiratory factors. It's quite common that a patient, not just in Alzheimer's disease, but a patient with other cardiac illnesses or respiratory illnesses would have difficulty or shortness of breath when lying flat. Polyuria or frequent urination may often wake a person and they may have difficulty getting back to sleep. Depression or anxiety may prevent a person from falling asleep because of ruminative thoughts. Caffeine and alcohol are very significant culprits for insomnia. And it's important to remember that the half-life of caffeine elimination is 5 hours. So many people may need to avoid caffeine after the noontime hour. So keep that in mind this afternoon. But you may need it for the talks. And then alcohol can have, a paradoxical effect. It may help a person fall asleep, but then can lead to nightmares, can lead to disrupted sleep, and then cause middle of the night or terminal insomnia. And finally, again, medications can play a role. If they have agitating or alerting effects, they may lead to insomnia. Okay, so circadian rhythm dysregulation. Again, this is a problem wherein a patient may be awake and agitated throughout the night, maybe eventually gets to sleep quite late at night, then sleeps late and maybe misses daycare, misses activities with family, and then takes naps and dozes during the daytime hours, and is off a normal or regular schedule and becomes difficult to care for and participate with other activities. And so this is quite common in Alzheimer's disease, and again, several causes, but it is important to note that in Alzheimer's disease, pathology has shown that there is some degeneration of these pacemaker neurons in the suprachiasmatic nucleus, which controls and regulates circadian rhythms and allows them to entrain with the night and day cycle. Decreased physical exercise may play a role, and if a patient is not exerting themselves during the day, then they may be staying up later in the evening. Decreased sunlight exposure can play a role as well, particularly in patients who may be in a nursing home or just have mobility problems and are not getting outside and then thus not receiving that stimulation through the retinal ganglion cells to the suprachiasmatic nucleus. And then nocturnal awakenings can be an issue. Ambient noise in the household, roommates, or bed checks if a person's in a nursing home or hospital will then disrupt their circadian rhythm. Okay, so now to speak a bit about the treatment of sleep disorders in Alzheimer's disease. First and most preferred is always behavioral. We'll speak a bit about the pharmacologic uses of sleeping aids in Alzheimer's disease, and then speak a bit about some promising ideas which have not yet played out as being effective, which would be bright light therapy and melatonin, although hope still remains. So the standard behavioral treatment for sleep disorders in Alzheimer's disease is similar to the treatment for sleep disorders in patients without dementia, but it becomes even more important in patients with Alzheimer's disease, and the first being maintenance of a regular routine. Of course, patients with dementia tend to respond best in a structured environment, and so maintenance of a very regular bedtime and awakening time is important for the treatment of these sleep disorders. Again, it's important to reduce the environmental noise and light in the bedroom, so maintaining a quiet, dark, and cool environment for sleep. And as much as possible to minimize nighttime awakenings. In nursing homes and hospitals, patients may be woken up to be administered medications, to have their vital signs checked, or have bed checks performed, and this can lead to significant disruptions in sleep and should be minimized. And how about the pharmacologic sleep aids? And it's important to note that none of the FDA-approved medications for insomnia have undergone trials specifically in patients with Alzheimer's disease. And so we don't have any data about which would be the best sleeping pill in a patient with Alzheimer's disease. And so with that being said, one may use any of the major classes of sleep aids, or at least may consider the use of them, but attention must be paid to their mechanism of action, their potential side effects, and of course their FDA warnings. And here's a table which runs through some of the sleep aids which are used, some of which are used on-label and some of which are used off-label. And they all have potential cautions, and all can theoretically be used, some more preferred than others. First, to consider the benzodiazepine. So this is drugs like clonazepam and temazepam. The importance here is to realize that patients can develop tolerance, they can develop physical dependence, and just as a factor of the way these medications work, by binding to and activating the GABA receptor, which is an inhibitory receptor in the nervous system, they can lead to amnesia and thus lead to some cognitive effects the next day. Not permanent, but they potentially may be noticeable in a patient. The non-benzodiazepine class of medications, they also act on this GABA receptor, but they're the newer drugs like zolpidem or Ambien and eszopiclone. They have some of the same cautions as the benzodiazepines, perhaps to a slightly lesser effect. And then they also have another interesting caution, which is called complex sleep behaviors, wherein a patient, after taking the medication, may have pretty complex behaviors, either eating, using the telephone, driving, or even having sexual activity, and having no recollection of the event. Some of the antidepressants are used for sleep aids, in particular drugs like amitriptyline and mirtazapine. However, these medications do have significant anticholinergic effects, and as we learned from Dr. Sewell, this can definitely precipitate some more delirium and behavioral problems, and so should be used with caution. Trazodone is a serotonin reuptake inhibitor, and I found in my practice that it tends to have lesser effects in that way and can be used. Melatonin and melatonin agonists certainly can be considered. The melatonin agonist, that's prescription is Melatonin, and melatonin is over the counter. And these don't have as many cautions over here, and so are perhaps milder to use and can be considered. Antihistamines like diphenhydramine or Benadryl, this is the group of medications that are found in the over-the-counter sleep aids like Tylenol PM, which are quite often used by patients and families to self-medicate. But again, they have a very high risk of leading to confusion because of their antihistamine and anticholinergic effects. And then finally, the atypical antipsychotics, which we've just learned quite a bit about. Of course, they have their FDA black box warning for mortality in the elderly, and use as a sleep aid is really quite off-label, although it is seen and done, but usually more in the setting where someone has nighttime sundowning and then can't fall asleep. But again, use with high caution. Now, bright light therapy, this is an interesting therapy which is being used in seasonal affective disorder, wherein patients can develop depression when they live in a place where there's a dark atmosphere during the winter. But this can also, this has been studied for circadian rhythm dysregulation. And the bright light box applies 10,000 luxes. That's the usual quantity, and a lux is 1 lumen per meter square. And usually it's applied for 30 minutes after awakening and to provide that light stimulation to the retinal ganglion cells and then the hypothalamus. And I just thought some interesting numbers. So the light box gives you 10,000 lux. The average indoor lighting is just 500 lux. But the average sunny summer day is 100,000 lux, so 10 times more than the bright light box. And so certainly, when possible, just getting outside early in the morning for 30 minutes would give you an even better effect. But for those who can't, that is how the bright light therapy works. And this has been tested in several different studies in patients with Alzheimer's disease or other dementias and circadian rhythm dysregulation. And the results have been varied. Some of the studies did show a benefit in terms of keeping the patient awake during the day and sleeping through the night, but not all of them did, and so it's not used in a standard fashion. Now a little bit more about melatonin. So as I mentioned, this is the hormone that's produced in the pineal gland, and it's secreted into the blood. It's synthesized from tryptophan, and it's secreted in the darkness and suppressed by light. So, and again, that linkage is through the hypothalamus. And when melatonin is secreted in the darkness, it causes some drowsiness and lowers the body temperature. And again, we have the hypothalamus here, and we have the pineal gland back here. And so there are some interesting links between melatonin and Alzheimer's disease. And first of all, it has been shown that the levels of melatonin receptor subtypes are decreased in certain areas of the brain in patients with Alzheimer's disease, as well as the retina. And so that's melatonin receptor subtypes decreased in the pineal gland and areas of the cortex. So there may be some evidence that patients with Alzheimer's disease have reduced sensitivity to melatonin. But furthermore, there's also been some biochemical studies and in vitro studies which show that melatonin may have some effects on some of the pathologic proteins in Alzheimer's disease. For example, there were some studies that showed melatonin reduced aggregation of amyloid beta. It prevented neuronal cell death caused by exposure to amyloid beta, and it also reduced hyperphosphorylation of tau. So there is some possibility that melatonin sensitivity may be reduced, but it may also, in Alzheimer's disease, but it may also be protective. So some interest has been in looking at melatonin as potentially a sleep aid in patients with Alzheimer's disease, or even as a cognitive enhancer. And 2 of the early small studies on melatonin as a sleep aid in Alzheimer's were positive, but the largest randomized control trial to date, which was conducted by the Alzheimer's Disease Cooperative Study, was negative. And in this study, 157 patients with Alzheimer's disease and sleep disturbance received melatonin or placebo. And the doses of melatonin they received were 2.5 milligram or 10 milligram. They tried 2 doses, and they were treated for 2 months. And the patients were observed with wrist actigraphy, which is like a little watch that a patient wears, which monitors motion, and thus you can extrapolate whether a patient is awake or asleep. And with this treatment, there was no differences seen in total sleep time, sleep efficiency, wake time after sleep onset, and day-night sleep ratio, unfortunately. And so there's not, at this time, good evidence that melatonin is actually helpful in circadian rhythm dysregulation in Alzheimer's disease. There was only thus far a small study for melatonin as a cognitive enhancer in Alzheimer's disease. It was very small. This used the dose of 3 milligrams of melatonin for 4 weeks' time. But interestingly, the patients on melatonin did have a small improvement on the ADAS-Cog, which is a standard scoring instrument in Alzheimer's disease. Okay, just a bit about obstructive sleep apnea in Alzheimer's disease. So obstructive sleep apnea is a condition where persons have recurrent pauses in their breathing during sleep due to obstruction in their upper airway, and they have oxygen desaturations. And it's quite important to note that obstructive sleep apnea is quite common. And an important study by Dr. Yaffe published last year showed that elderly women with sleep-disordered breathing, which is a looser definition of obstructive sleep apnea, are at higher risk of later developing MCI and dementia than those who didn't have the sleep-disordered breathing. And so obstructive sleep apnea may be a risk factor for Alzheimer's disease. But it's also important to note that when obstructive sleep apnea is present in patients with Alzheimer's disease, more severe sleep apnea is associated with more severe cognitive impairment. And the areas of cognition most affected by obstructive sleep apnea are attention, initiation, conceptualization, and memory. And treatment of obstructive sleep apnea with CPAP can improve some of these cognitive changes in Alzheimer's disease to a small degree. But of course, treatment with the CPAP machine can sometimes be challenging in patients with dementia. As far as sleep disruptions and other types of dementia, in vascular dementia, the main to be concerned with is obstructive sleep apnea because there is such a high coincidence and there's a higher risk of further stroke in patients with obstructive sleep apnea. And the main sleep disruption to be aware of in dementia with Lewy bodies is REM behavior disorder, which is a condition where patients, during their dreams, they are not paralyzed. They enact their dreams, and this can result in motor activity during sleep and put the patient and their bed partner at risk for injuries. And for REM sleep disorder, the diagnosis is made by a sleep study, and the treatment is to ensure a safe sleeping environment, and clonazepam at bedtime can be effective in treating up to 80% of patients with REM sleep behavior disorder. And so overall, the conclusions are that these sleep disorders are very common in Alzheimer's disease and other dementias. Diagnosis requires careful history and physical, and other studies like actigraphy and polysomnography may also be helpful. And there are numerous behavioral and pharmacologic treatments which are available, but they remain challenging to treat. Thank you very much.
We'll take a few questions now from the audience. So we have one here on the right side.
I was wondering if by prescribing sleep aids to seniors, they might sleep longer, but is the quality of sleep better? Are they getting that REM sleep, or are they just out? Has there been a study on that?
That's a good question. The quality of sleep is not necessarily better. In fact, some of the sleep aids do further reduce the REM sleep. And so it's a very challenging decision whether to use a sleep aid or whether to just muddle along with behavioral methods as best we can.
On the left side.
Can you say something about the occurrence of sleep disorders in the progression of Alzheimer's disease? Some caregivers have noted that it's a cycle that if you endure it for what seems like months at a time, but nevertheless it's a cycle that the patient grows out of?
I think that is, in my experience, I would agree that that's the case. They don't tend to be permanent, and they tend to be temporary, although perhaps a bit prolonged. I don't think there's a lot of data necessarily, though, that can show that that's the case.
Okay, let's take one more question over here.
Have you found that physical activity affects sleep with Alzheimer and dementia patients, those that are able to be active?
So I think that in my experience that is the case, and it is beneficial and healthy to do physical exercise more earlier in the day rather than late in the day, and that can lead to more restful and better sleep in the evening.
Okay, thank you. So great talk, Aimee.